So now I'm going to go ahead and teach you the Laslett sequence. I'm going to incorporate every test individually from the start to the end in the proper order. So beginning with the sacral, distraction test. This one will be for the anterior SI ligaments, and this is going to be testing if they have any reproduction of pain in that area in the low back, or it could even go down as unilateral posterior glute and leg pain. So what I'm going to do is I'll find the iliac crests and I'll go down to the ASIS. And to perform this, you will cross your hands in the front. Be very careful to the ASIS because this could be tender for the patients. And I'm just going to compress or push out. And a positive test would be, as I said, pain in that area or reproduction of symptoms. So the next test from that sequence for Laslett is going to be the thigh thrust. So I'm going to passively move the leg up in deflection. I'll ask the patient to slightly rotate off the table carefully, putting my hand behind the joint line of the SI joint. Bring their leg up, and I will do a quick force down. And again, this will be a reproduction of pain in that area unilaterally posterior down the leg. The third component of this Laslett is going to be called the sacral thrust. So I'm going to ask Alex to please roll on her stomach. From here, I will then have her nice and flat, find my points of the sacrum, go down to the apex of that area, and again, with a really quick thrust, I will go ahead and apply that test. And again, pain would be unilateral down the leg on one side. And the last one, Alex, please lay back on your back, is going to be the final component. And this is going to be the compression. And again, instead of crossing my hands, I'm going to keep them apart. And I'm going to compress, find the be then stressing the posterior SI ligaments. Again, pain unilateral down the area of affected complaints. This test is called the supine active straight leg raised test. So what I will have the patient do is I'm going to have them actively lift up their leg, and I should hear complaints of pain or discomfort. I'll have her lower it down again. Then from there, she'll rate. I will then add compression to her. Good. I find the points where I need. Sorry about that. Find the ilium. Then from the ilium, then I add the compression. And if she talks about a reduction of pain with doing a straight leg raise with that, then that's going to be a positive that there is, for this test, that there could be some instability in that joint, and there is a weakness with the muscles that are actually holding it together for compression. The second part of the active straight leg raise, if I did not want to do compression, is I can have the patient actually activate this stability with her own muscle use. So again, I will have her raise up the affected leg and have her move up with some rotation, applying some resistance to the forward shoulder. And with this, if there's a reduction in pain, that will also be a positive test for this as well. Next is the prone straight leg raise test, and I'm going to have the patient raise up one leg all the way up, and if I hear signs of a production of pain similar to for what they were coming in for, I will then find the ilium. Then I'll put my compression, have them do the same motion, and if there's a reduction in that pain, I know that this is a positive. Another way of doing this test to reduce me actually doing the passive compression is have them activate the support with use of the sling system with their muscles. So again, raise up that left leg all the way up, and then I will now push down on the arm for that latissimus dorsi, and if there's a reduction of pain for that, again, that's a positive for this test. This next test is called the supine to sit test. And this is going to be checking to see if there is an anterior posterior rotation of the innominates leading to a leg length discrepancy. For example, if I were to test the patient's left leg and they were in this supine position and the leg appeared longer, then I would have the patient get into a seated position and check that affected side. If it appeared shorter when in sitting, this would test positive for an anterior innominate rotation on that affected side. This next test is called the hip scour test, and this is going to be for hip potential OA or any degeneration within the actual intracapsular itself. So passively, I'm going to bring the hip up into flexion with knee flexion. From here, I'm going to stabilize my base of support, and I'm going to hold her and push some compression with my body. Moving in a semicircular motion from adduction to abduction, I'm feeling for any crepitus, I'm feeling for any pain, or I'm feeling for any audible complaints from the patient that are similar for what they were coming in for. And that would be a positive sign. So these next tests I'm going to do is fade DERS to start with, so external rotation. And this is checking for intra-articular issues at the joint. So I'm going to passively flex her hip, and I'm going to put her leg on top of her opposite extremity. From here, I'm going to be saying, relax as much as possible. Just let gravity, let your hip fall. And then if it gets to a range it can't go anymore, I may put a little bit more pressure just to see how it feels. And with the tape measure, I'm going to measure from the knee to the area of the table. And if it is above or at 4 centimeters, I'm going to say that is a positive test for hip issues. And the next one I'm going to do is fade DIR, IR, internal rotation. And again, this is checking for that interarticular issues, and this one more so with FAI as well. So from here, I'm going to flex the hip to 90, flex the knee to 90 as well, and I'm going to add some internal rotation to the hip. And if there is any pain expressed that is similar to what they came in for, or any limitations with that motion, this is a positive test. For this next test, it will be more so for the younger population, for older children or young adults. It is called the flexion adduction test. And what I'm going to do is passively flex the leg that I'm testing up to 40 degrees of hip flexion, 90 degrees of knee flexion. And with this, I will passively push the leg into adduction. Normally, what I should see is this, what I do. The knee is rounding in front of the opposite leg that's extended. If this was a positive test, there would be some limitation, and I would not get the adduction, and there would possibly be an expression of pain similar to what their chief complaint was. This test is the log roll test, and it is testing for intra-articular issues at the joint and in the hip. So what I will do is passively rotate the leg fully into internal rotation to that end point, and then I will let go. And I should see the leg roll back into external rotation. If I see any abnormalities with this, or there's pain generated within this motion, or there was an limitation with the external rotation, this is a positive for intra-articular issues. So this is going to be the test for the anterior labral tear test. So for this one, I'm going to passively move them from a flexed hip 90-degree position, and I'm going to have them initially into an abducted and external rotation of the hip. And from here, I'm going to then move them passively into adduction and internal rotation. And a positive test would be an increase in pain from what their chief complaint was, or if there was any grinding or clicking as well. Testing the posterior labral tear test, I'm going to passively move the affected leg to 90 degrees of hip flexion, 90 degrees of knee flexion. And I'm going to then, starting off, have them into a adducted position with internal rotation. From there, I'm going to passively move them into external rotation with abduction. And a positive sign for this one would be pain, a reproduction of symptoms, or grinding once that motion was done. This next test is going to be called the Craig's test, and it is testing for hip anteversion or hip retroversion. So with the patient prone, I will first have them move their body down so that their knees are off the edge of the table, so it's going to be a little bit easier for me to measure with my goniometer. Starting with them in this position with their knees slightly bent, I'm going to find that neutral position of their hip. And with that done, it is usually when the hip and the greater trochanter is in its most prominent position, which for Alex, I feel it when it's like right here. So I'll have her hold this. I will also kind of hold this position as well. Get my goniometer out and measure where it is in alignment with. So if I see that it is greater than 15 degrees, this is significant for hip anteversion. If I notice that it is less than 8 degrees, this is significant for hip retroversion. And for Alex, she's within that 8 to 15 degree range. This is going to be called the fulcrum test, and it's going to be assessing for any stress fractures or any superior patellar femoral fractures. So what I'll do is put my arm underneath their tested leg. And from here, I'm just going to push down and create that fulcrum force. And a positive sign would be if she had any elicited pain on that tested leg. This next test is going to be called the patellar pubic percussion test, and it is going to be assessing for any stress fractures or any femoral neck fractures to the superior aspect of that bone. So I'm going to ask Alex to please place this on the pubic symphysis. From there, I will tap on one of the patellas, compare it to the opposite side. I could do this a few times just to verify I'm getting the exact same pitch on both sides, because a positive sign would be if there's any dull or heaviness on one side once I do the percussion. This test is going to be the Trans-Dellenberg test, and it's going to assess for glute med weakness or glute med inability for it to actually fire. So I will have Alex choose whichever side she wants to stand on. I will have the patient usually stand on this for up to 30 seconds. And what I'm assessing is if there's any drop on her pelvis. So since she's neutral, I know that the stance leg for the glute med is strong, but if I saw a drop in the pelvis on the side, I would then know that there was glute med weakness on the stance side on this patient's left leg. You're right. So this is going to be the Eli's test, and it's testing for rectus femoris tightness, So if I were to test Alex's left side, I would be passively flexing her knee, and I would give it some compression. And what I'm assessing for is a lifting of the same pelvis from the table, which would indicate rectus femoris tightness. Next is going to be the piriformis test. So I will have Alex flex her hips to about 60 degrees. If you could just come up just slightly from the table, that'd be great. And then this top leg, I just want to make sure that it's off of the table slightly, the top knee. So I would stabilize the pelvis so she doesn't fall, and I would give some compression over this piriformis as such. And a positive would be pain in the posterior side of that leg with a possible sciatic inclusion, just due to the piriformis and that being combined if that was an irritation to that muscle, which would be a positive test. This test is going to be called the derotation test, which is testing for a potential glute tendinopathy. Passively putting the patient in the hip flexion and external rotation, I'm going to ask her to, against my resistance, try and bring her leg back to a neutral position and go for it. Giving her some resistance from that eccentric contraction. A positive sign would be any pain or reproduction of symptoms. If they had no pain with that, Alex, would you please lay onto your stomach into a prone position? I would then ask her to get into this position if there was no pain. Again, flex her knee, but this time her hip is in extension. I will put her into hip external rotation, relax. And then from here, I will tell her to go back into a neutral position against my resistance. So go for it. Good, 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 go, 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 go. Good. And a positive sign for this would be that reproduction of symptoms. If this was also negative, then I would know for sure with very high ratings of research that there was going to be no tendinopathy. On to now the sign of the buttock, which is assessing for a potential neoplasm inside the hip joint. So passively, I will straighten the leg for hip flexion with the knee straight. If this was the amount that I could get to without a blockage, I will then bend the knee and I will try and flex the hip further. If there was a block, I was not able to successfully increase that hip range of motion, this would be a positive for that potential neoplasm in the hip. To complete the long axis distraction, I'm going to figure eight the gait belt, excuse me, not the gait belt, the mobility belt through my hands. There we go. From there, I'll put the patient's foot completely through, getting a good grip through the distal tibiofibular joint. From there, with my hands applied, slight hip flexion, and I'm going to let my body weight fall. And I'm just going to go ahead and maybe rotate it into abduction, into adduction. And I can hold my glide. Not oscillations, just because this will be more comfortable for the patient. And I can hold this for about 10 to 15 seconds, and then I could give her a break, and then we could do that again. For lateral distraction, I'm going to adjust the area of where the belt hits me around my hips. And I had Alex place it in the most lowest comfortable area near her groin for her comfort. So from here, cradling her leg, I'm going to just go ahead and make sure the table is at the point in line of force. And I'm just going to slowly just start to sit back and feel that distraction. And if I wanted to, based off of where I found her greatest areas of stiffness, I could put her in some hip external rotation and just hold. And if I felt like I had some limitations with internal rotation, again, take her to that comfortable point and just hold and distract. And this would be comfortable for the patients who have that stiffness. I'm having a grade 3, grade 4. And if I wanted it for just pain management, it would be a grade 1, grade 2. So to complete a anterior to posterior glide, I'm going to have the belt around me. I'm going to stick her leg inside. As we were taught, make sure that the table is nice and low so that I don't have to overly work to have the hip in that open packed position. So from here, I'm just going to go ahead and, actually for my comfort, we're going to do it like this. And then go ahead and go inside. Much better. So again, stand up, have the leg in that open packed position. Are you comfortable? Mm-hmm. Okay. And then from here, I'm just going to go ahead and find that greater trochanter. Great. And you really want to make sure that you're on that comfortable point of the hip so it's not uncomfortable for the patient. Good. Make sure that her leg's a little bit more inside. And then from here, I'm just going to go ahead and do my gentle glides down. So for here, I'm just going to go ahead and go down to my grade 4 and just hold. If I wanted to, I could do my oscillations as well. And as we know, this is going to be increasing, since I'm going to be pushing on the convex side, I'm going to be increasing extension with an anterior to posterior glide for this motion. And now to show a PA glide posterior to anterior, which will, in hope, increase hip flexion. I will put the belt around her leg. Excuse me, much better this way. Making sure that it's on a comfortable part for the patient. Again, standing up. And now from here, I might put a little bit less resistance on it for my comfort. Much better. And then from here, what I can do is again find that greater trochanter. Good. Alex, if you could just come slightly closer to me, just to make sure that her hip is in that proper alignment. Again, just for my comfort, I'm going to give a little bit less resistance. Much better. You want the alignment to be straight. You don't want her to be in either adduction or abduction. And then from here, find the head of the greater trochanter, which I'm on, and then you can go ahead and do your mobs again. So, get to that grade 4, do the tiny motions at that end range, or I can give a little bit less and go to greater motions for that 3, and I can go ahead and push it as such. Again, increasing hip flexion for the grade 3, 4 for stiffness.